Thank you very much, Gina, Gabriella, Mr. President, for inviting me. I'm so pleased to be here today. It's such a privilege in this very beautiful forum, and I look forward to sharing some of the experiences in Australia that we have had. So you can see that I come from the Parent-Infant Research Institute, and that I'm director of the Parent-Infant Research Institute, but I'm also a clinician. I'm director of clinical services in a hospital, and I'm a professor at the University of Melbourne. So I bring all my experiences together. Let me tell you a little bit about the Parent-Infant Research Institute. It's an independent, not-for-profit organisation, and the hospital where I work has kindly offered us rooms. I also, as you heard, work at the University of Melbourne. This is my hospital. It's a view. It has 600 beds, and that's where we live. Of course, you know it's in Australia, and so we are interested in mother-baby work of all sorts, and you can see the little, that was not good. Sorry. Okay. You can see the little baby here, the bambino. So, what is special, I think, about our institute? The Parent-Infant Research Institute is called PIRI, and we have a board, of course, that we report to. But also we are clinicians and researchers. So we bring people who are working with mothers and babies all the time, as well as academics. What we do centrally is we do research. So as you can see, research is in the middle, but from that, we also have a clinic because we run trials, and so we have a clinic associated. We do a lot of teaching, and we also do public health initiatives like screening. And so what is our mission? Our mission is big. We hope to support all parents and babies in the first 1,000 days of life, before pregnancy and throughout the first year, and to support parents and families with perinatal depression and anxiety, and to tackle these problems through research and also through translating our research to practice. So, you've already heard a lot about what depression is, but I will just for a moment say the same thing so that you can know what we mean when we talk about depression. So, of course, many women suffer the baby blues, 80%, but postnatal depression is those 10 or 20% of women who, probably peaking around 6 to 8 weeks and at 3 months, begin to feel depressed and consistently feel depressed after birth. We are not going to talk so much about psychosis. Sorry, is the sound better? Yeah. Today, but of course that is a very important condition that we should all be aware of when we work with these women. We generally work with women who have a diagnosis. So as you know and heard from DSM-5, we need 2 symptoms, depressed mood or loss of interest, and at least 4 symptoms over a 2-week period. But over time we have become interested too in women who have less symptoms, because that can have an impact on everything too. But in terms of the strict criteria, how many women have postnatal depression? Well, really, there are not so many studies that give us very good figures. So 13% is about the best figure that we have. 13%. At 3 months, 13% of women. But over 1 year, it will be more women after the birth of the baby. So now let me talk a bit too about anxiety, because we really need to always remember we are not just dealing with depression, but anxiety, which is highly comorbid. It can be concentrated on the baby or on the self with symptoms. And so we call depression and anxiety common perinatal disorders because they happen in 1 in 10 women. They're very common, and some women are more vulnerable. Depression is common, anxiety is common, and we can have a range of disorders. And what is actually interesting is that it's not always generalized anxiety disorder that's obvious after birth. Louise Howard talks about phobias being very present. So what about the less common mental health disorders? Again, I'm not going to concentrate today. I mentioned that psychosis is, Mattel? Thank you. That psychosis is very rare, and it's very immediate, and it happens in the 4 weeks after birth, and so we have to have all professionals working in the field recognize the difference between the different presentations, but this, of course, is accompanied by delusional beliefs and other very severe symptoms and needs hospitalization. But I'm not going to talk about that today, or bipolar affective disorders, and I'm also not going to be talking about schizophrenia very much, except to say that we all need to be educated and be able to recognize and assess. So have a look at the different prevalence. As you see, the baby blues are very common. Then we have postnatal depression and anxiety, which is about 10%, and the less common disorders. Of course, as we heard this morning already, we are very concerned about the consequences from pregnancy. And there's increasing understanding that we need to focus on antenatal depression in pregnancy. It's one of the most powerful predictors of postnatal depression. And it also, of course, has other effects on birth outcomes and preterm birth, sometimes mediated through associated lifestyle factors. And postnatally, the consequences are huge. Of course, the woman herself, what a distressing, terrible condition for women. The impact on the baby needs to be central because 60% have dysfunctional relationships, and we know the babies go on to have difficulties. And of course, the partner relationship is at risk. It's a risk factor, but it also becomes at risk. So we need to intervene early. And the mission of PIRI has been to reduce the effects of PND and antenatal depression, and to bring back the joy in women's lives. Oops, the music is supposed to come on now. Mattel, I can't do it. Can you start the music? No? So we use music a lot, and so that is our aim. I aim to bring back the music and the joy in people's lives, and this is one tune that we use in our mother-baby programs. And you've already been listening for a while, so it's a chance to stretch and to take a moment and exactly, yeah, that's right. It's a long time to sit and listen. So, the Parent Infant Research Institute, PIRI, was established in 2001. And I'll tell you just a little bit about how I came to establish PIRI. So, when I was a student, I got a fellowship to the United States. And I was able to study different modalities of therapy. And when I came back, I soon became head of a department in a hospital that has allowed me to do wonderful things. It has given me a lot of freedom to develop many different things. And one of the turning factors was in 1993 when I went to France on a fellowship from the hospital. And I worked with Dr. Lebovitzy, who was an amazing infant mental health specialist. And as a result, I came back and I said, I must do it, and I developed an infant clinic. And it wasn't easy because in Australia, at that time, people were treating depression, but not the mother-baby relationship. And so sometimes I felt like this little cat here, and I tried to pretend that I was the lion. So in 2001, we established the Parent Infant Research Institute, and also I was very fortunate that we won the opportunity to be part of a national postnatal depression program. Now, what was this? This was a collaboration between experts right across Australia to try and lead the way for perinatal mental health. This is in 2001. And the first phase was called the National Postnatal Depression Program, and I will share it with you because it's so wonderful to hear of what you are developing here, and maybe and to hear the regional screening efforts we just heard. Thank you. And to maybe there are some things in our history that might also be useful. So I'll talk first a lot about that, and then we went on to develop a national action plan, and then the government picked it up, and I'll talk about how that came about. And we had a national perinatal initiative. So that's the steps we took. Many little steps over many years. It takes time, but if you set your vision, I think that is the way to do it. So that was the logo we had in phase 1. So what were we asked to do? We were asked to look at the feasibility of screening and early intervention in Australia and see if we could do it. And so there were a number of different states. We have 8 states and territories. And we also, same thing, we wanted to increase awareness, and we also wanted to do some research. So it was very ambitious. We had 40 different health services, 43, 8 states, and PIRI, my institute, was able to be leading 2 states. And by the end, we were able to screen 40,000 women and reach 200,000, and that had never been done in Australia before, so we had to go to hospitals, and it was a new idea. And we also developed many booklets, which I'll show you later. So very quickly, you know, we also had research. We evaluated all mothers. It was a fantastic database. We had, you know, over 200,000 women that we had a database. We tried to then screen all women in different states. And each of the states had a research project that they could do. And you will see later, I will talk about what PIRI did. And then afterwards, we did postnatal screening. We started in the hospitals and maternity hospitals, and then we did postnatal screening, and then we followed up and tried to get some data. So what we wanted to do was to make sure that routine universal screening was feasible, much like you are doing now. And we also wanted to see how to develop pathways of care, of course, workforce training, and increase awareness. So you will see that in some of our programs we use humour. It helps a lot. And even when women are depressed, they relate to cartoons. So that says, you know, how's motherhood? Wonderful, amazing, scary, exhausting. It's all those things. So let me tell you about the screening that we did. Of course, we were trying to find the women who not just had a diagnosis, but maybe had elevated symptoms of depression. So we know that if you're talking about perinatal depression from pregnancy to maybe 2 years, you're talking to at least 1 in 5 women. But, What is really sad is that very few women receive the treatment that they need. Maybe if you look at international studies we have so far, and I'll be interested to see yours, only 10% get the treatment that they need. So we needed to reach these women. So we know why to screen. We know that perinatal depression is serious, has consequences, is common, can be treated successfully, which we've shown also, but importantly, most women will not seek help. And we know we have a tool that is a good tool, the EPDS, and that it's acceptable. So what we're doing and what we are still doing today is to move past screening to try to increase the number of women who will receive help. And what are the barriers to seeking help? Well, I'm sure they're the same in Italy as they are in Australia. Is feeling tired, which is a symptom of depression, and a bit exhausted and sad and so on, part of normal motherhood. Being unsure what depression is, not knowing where to seek help, not knowing what symptoms. There's also attitudes that still get in the road. It's still hard sometimes to disclose emotional problems to health professionals or to family. And when you're depressed, you're often confused and you lack motivation, so it's very hard. It's harder than usual to ask for what you need. And the stigma, of course, what will other people think? So we call postnatal depression for many women still, the hidden illness. You know, it is hidden because of all the reasons which we talk about, such as the stigma and the shame and the expectations. So John Cox did some very good work and developed the Edinburgh, but we have to remember that that is a screening tool and only the beginning, but a very good screening tool, because we know what it does and what it doesn't do. And that is why we like the Edinburgh, because we understand it. So you've seen what the items are, no doubt. I'll just go back one because, of course, we talk about item 10, which is the thought of harming myself. And so when we screen, we also always need to keep an eye out for that item. So what does screening do? Screening gives us a subgroup that are likely or have a high prevalence of depression, but it can't diagnose depression. It doesn't predict who is going to become depressed necessarily. It performs actually similarly to the Beck Depression Inventory, and its positive predictive value is 62%. So 6 out of 10 women who score more than 13 will be likely to get a diagnosis. I won't go over the details, but except to remind you always to remember that, because when we have the Edinburgh in the field, it's amazing how it starts to become a tool that people say, oh, you are depressed, you have a score more than 13, and that's not always true. So how do we move from screening to the next stage? That was, we have to go, and that was what we did in our work. We wanted to go from depression to diagnostic assessment, to broader psychosocial factors, to then having a management plan for every woman. Well, we're still working on it. So the full assessment and pathways to care is really the hard part. Screening is the beginning. We need to, I think I liked what you said about biopsychosocial models, but we also need to think about multidisciplinary teams. We need all our health professional workers to be educated and trained, and there still is some debate in some areas. Is it acceptable? Is it feasible? I think a lot of the work we did showed that it was. Oh, by the way, if you screen with depression, with the Edinburgh, sometimes you find other disorders as well. It will pick up other disorders, not just major depressive disorders. So we found in our studies in this program that it was acceptable. And in 1994, Cox and Holden already said that a lot of women found it a relief to be asked about their feelings. But what we found is it depends how it is given to you, and it depends on what happens afterwards. Because if it's just a piece of paper here, tell us how you feel, take it back, it's not going to really be a very good tool. But we found in the National Postnatal Depression Program, most women found it easy to complete, they didn't experience discomfort. We telephoned women and talked to them about how they found it. We actually found that in pregnant women, for example, we telephoned them 1 or 2 weeks later and we said, what was it like to be screened? And most women actually had no difficulties, which was really good. That's what it looked like. There were a lot that were from comfortable to not very comfortable. But remember, there will always be some women who find it difficult. And for postnatal women, we had some very nice messages. It was good to know someone was looking. It made me think truthfully about how I really was feeling. It wasn't all in my head. There is something that's happening that isn't good. And it's positive to know that there's someone there if I need help. So that was all good. The midwives also said it was good to be able to screen. So they're your nurses here in the antenatal clinics. They like the questionnaires, but sometimes they find it hard because they're so busy. They don't have the time to screen. And sometimes they don't know what to do when somebody starts to cry or the score is very high. So why it should be supported? Well, we found that the case for is bigger than the case against, but we at least know what we need to do to tackle the problems. And most importantly, I think that screening is permission to speak and permission to listen. So that was the end of phase 1. We learned that, yes, we were able to show the same statistics, 1 in 10 women. Yes, it's feasible and acceptable. We were able to do some little bits of training, and it was very successful. And there's more work to be done to decrease stigma and barriers. And we need to work with everybody, all the professionals that you see here. So we have our mental health specialists, our GPs, our nurses, family, and the general community. And during that time, it was an organisation called Beyond Blue that is a government organisation dedicated to depression in general, and they funded the National Postnatal Depression Program. And we developed many booklets and brochures, and I'm just going to show them to you very quickly. So we developed a booklet, quite a long booklet, for mothers to understand what depression is. And you can see that Piri developed the first version. We developed posters. We developed guides to professionals so they could understand what the Edinburgh means. Lots of guides. We developed brochures for professionals about the effect on the baby, and this was written by Piri. We developed, later, every few years, it was upgraded, the booklet, and different ones for twins have special problems, and different cultural groups now. And a checklist where women, if they wanted to look at what they were doing. So you can see that there were many, many things, including helplines that we could give women and professionals. So what did we do next? Well, we had done this good work for 5 years, and Beyond Blue decided that we needed to develop a national action plan. So they brought together again a bigger group of experts to write up the results of the study and to submit to government. And the National Action Plan, not surprisingly, recommended that routine screening and psychosocial assessment should happen for every woman, and training and pathways to care should be available. So we had a working group, and we had to bring in different, our Indigenous people as well. And then the most amazing thing happened. The government decided to take it up for the whole nation and gave 55 million to make that a framework that should start to be developed across Australia. It was quite unbelievable to go from research to a whole government approach. Was wonderful. And this was a major achievement. And it was until about 2013 that the money was available. That money is no longer available, but it was not to enforce it, but for different states to develop processes to try and promote it. It wasn't always spent in the best way, because it wasn't quite, all the different states did different things. But one of the things that was very good is we developed national guidelines for perinatal depression. So there was a group brought together, it was very scientific, expert advisory committee, and we made recommendations. And I won't talk about it much, except it said to use the Edinburgh, it talked about when, and then it talked about recommendations for treatment. And what it did was it summarised the research evidence. So what we saw, though, is that, level A is very high and level B is trusted and so on, but, you are still working with evidence that is not at the highest A level. So you can see that the recommendations in 2008, they were not necessarily level A evidence, because there are still a lot of research questions we don't really know. But there's wonderful research happening and it's getting better. There were again more documents prepared, and we also focused on psychosocial assessment. So we all know that it's good to detect women who are depressed and anxious, but as we heard today, it doesn't occur in a vacuum. A woman has a life, has other things happening, many other factors. So there are many factors. Some of them are here. So I have put some here. But this afternoon you will hear from Pina about migrant women and ethnic groups, and there are other factors that are being elucidated. But these are some of the recurrent and important risk factors. And domestic violence and child abuse are emerging as well. So we're up to broader assessment. Now we need to manage it. So what do we do, given we know we have all these women, and how do we make available to all the women, if you count the number of births that you have in Italy, and you find 20% of women who need help, how will you reach all those women? And that is an ongoing challenge. But what is very rewarding, that it is better to do something than nothing, is what we find, and that sometimes quite low intensity interventions can also be useful. So training professionals is really important, because right from the beginning you can upskill your nurses and other people to do some very basic work. And who are we talking about? GPs, midwives, obstetricians, paediatricians, psychiatrists. The psychologists are not there. I don't know why, because of course I'm a psychologist, but of course they're important. And we need to, for the nurses, we need to help them feel comfortable with depression and anxiety. That's what they want. They want to be able to see it coming, recognise it, feel in control. And what women want is the right person at the right time to understand what to help me with. I'm going just a little bit faster because we're a little bit late in the time. But what we developed was different levels of training. So you would provide different training for GPs, to maybe a nurse, to maybe a psychologist. So we developed a matrix of training and different training courses. And PIRI developed an online training course for GPs and health professionals, which was with Beyond Blue funding, which was very successful. And the sorts of things that we had in the online training for nurses were, we teach them on an online course how to screen, how to do an assessment, because with training, some obviously GPs can go on to assessments, some enhanced nurses, advanced nurses, we're interested in becoming able to go one more step and be able to go to the next step. And so the training was very successful. It used case studies. So there was assessment guidelines. There were diagnostic guidelines in the online training program. What to do if it's 13. And, it really helped a professional to know what the different scores mean. And of course, we have to help with the risk of infanticide and suicide. So how does a nurse who is not a mental health specialist ask about, have you ever had thoughts towards your baby of harming your baby? And we would suggest how you can speak to a mother. And when you become more comfortable asking the question, it's not so frightening for some nurses, and some need more support and training. And not just to ask the first question, but if they say yes, to be able to ask, what did you do? Now, if you are screening someone and she scores very high and she scores on the suicidal item, I don't know about your system, but you need to mobilize some help straight away. And it's very helpful for all professions to understand the elements of risk assessment. It's not that mysterious. There are some very clear protocols about how you develop it. And so we use case studies, about how you ask about the suicidal thoughts, about planning, about lethality, about means. Because if you cover these things, you have an idea of how serious the risk is and whether you should let the woman go home while you refer her somewhere, or whether you need to, get the husband to come in, take her home, contact the hospital or whatever. And what treatments work, obviously both psychological and pharmacological, and we heard today too about that there needs to be a balance, and sometimes psychological treatment is not offered as a first-line approach, which we know for pregnant, and if it's a moderate depression, can be very effective, and sometimes we need to have medication available. So how to balance that? So also when we train health professionals, we can't underestimate the approach. When we talk to women, it's how the professional gave them the Edinburgh, talked to them about anything that made all the difference about whether they went on to get treatment or not. I know it's obvious to all of you, but it's just something that needs to be, you don't have to be a clinical psychologist to do these things. It's part of the health professional training that we were able to reinforce as so important to these mothers, and also to help these mothers feel that it's quite common. A lot of mothers feel like this. It's not a sign of failure. You will see, I will talk in part 2, after you've had some coffee, about how we are helping nurses to make a management plan. So not just screen, but to make a management plan. So I will do that afterwards. So that was what we did in Australia to get to a certain point, to about 2013. At the same time, At Piri, we were doing research, of course, because that's what we do. So in parallel, we were continuing to do research to support these major exercises in the community. So what were some of the things? You don't need to read the little writing, but we have a strategy where we want, you probably can't see it very well, but we want to go from understanding more, that's to developing better interventions, to improving help seeking, and you will see to moving into e-health, electronic digital platforms. So what we want to do is to be able to develop help at every level. So this is a model we developed. We want to be able to have things for all parents. All parents. Now, all parents, all new parents, for example, have a problem sometime, usually, unless you're very lucky, with sleeping, with feeding, and with all those things. So that sort of information is available like the foundation at the bottom. And we have some resources now for that. At the next level, at the screening level, we need to be able to help women have information about, well, what does it mean if you got a high score? So women are informed about what that is. At the next level, we want to think about prevention. What about those women who have some symptoms, who, you know, what do we know about prevention? And I'm not going to talk a lot about prevention, but it is very interesting because, you know, we still don't have the key to prevention. But we do know that, for example, you know, intervening early is a good idea. And so I will talk a little bit about some of our prevention tools towards parenthood. And at the next level, we want to have treatments. And first we started developing treatments especially for mothers who are depressed. There's many good treatments psychologically for depression. But, you know, you can't have a depressed mother and say to her, go and relax for 20 minutes, go to your room, shut the door, don't let anyone disturb you. So, you know, we have relaxation on the run. You know, how do you do it when you're doing 20 things as well? So at the very top, of course, we always need our specialist services, our mother-baby units, Susan, wherever you are, and so on. There. So that's what we set about, developing that both for initially for traditional services and more recently for e-health services. So we kept doing research, right? And we did research at the beginning on treating postnatal depression and anxiety, and some of you know that tomorrow I'll be talking a little bit about some of the tools for treating depression, of how to help women when they can't cope, when they don't know what to do, when they might have slipped into a more serious depression. And so these are all the tools that we developed, but we started with our face-to-face program, which I'll do a workshop on tomorrow, and the latest, which I'll talk about today, is our e-mental health program, and we'll talk about that after the break. I'll talk about some of the other programs that we developed, which include some mother-baby programs, and some pregnancy programs. So we had to develop programs for pregnant women a bit separate. We developed mother-baby programs, which are very important as well. So this is just a picture of our program for treating postnatal depression, which is, as you know, published in Italian. Thank you very much. And in this book, there's actually the manual. Ah, you have the book. Thank you. Thank you, because I only had the Australian book, so you can hold it up. You have the Italian one. But it is written so that a clinician who has some training in cognitive behavioral therapy can pick it up and use it. And I hope it has been helpful. And we'll see that later that Gabriella did some research on that. So it has a very detailed manual in there. And the research evidence in Australia, we have now trialled that program in many different cohorts, lots of evidence. In Italy, Gabriella, who is probably up there helping the translators, has done some work of using our program in a project funded by the Ministry of Health, looking at whether our program, either as a group program or individually, made a difference. And of course, she had many other people working with her. So you can see that these are just some of the people who worked on this project. And Gina, I know, is very involved in everything, always. Also there was some very interesting screening results where they started off screening. So they were following really our model. They were looking at screening in Italy, and not surprisingly, you know, they again found that out of, they screened how many women and found a 7% rate, you know, so it's always within that around 10% rate that comes up. But what was really wonderful for us is that it seemed that the treatment in Italy worked like it works in Australia. It wasn't a randomised trial, but we have done many randomised trials, and what you can see is that women came in with a high Edinburgh, a high Beck, a high anxiety. This is at baseline. At time 1, started going down. At time 2, 6 months later, they were able to maintain the gains. So we were very pleased that it was able to be used cross-culturally, and it's also been used in other countries as well. I'll tell you just a little bit about some of our other programs towards parenthood, which has also been translated in Italian. And that is because when we started, this was part of the remember the National Postnatal Depression Program in 2001? At that time, when you went to a birth class, it was all about how you breathe, how you go through the birth. There was very little about how you prepare psychologically for the birth of the new baby. And so we had some clinicians, and we developed quite a serious intervention, but in a very light-hearted way, so that women and their partners could sit down and do some exercises to start thinking about life after the baby. Because we know there's some things we can't change, like past history. But we do know that low partner support is a risk factor, so we wanted the partners to come in. We do know that antenatal depression will affect postnatal depression. So if we could start to prepare women for what signs to look for if they were already depressed, to take some action, to start attaching to the baby, to look at their relationship, all these things, and to be able to think about all those things. And so there were a number of modules. One was called Towards Motherhood, and I won't cover it all, but it's getting to know your baby, what do babies need, being realistic, and very importantly, you know, my family, myself, how do I think about being a mother, especially for first mothers? What do I bring from my past that is different from what my partner is going to bring? And they do an exercise. What's important to you? What's important to you? Have a look at it together. And also about looking after yourself. I think it's a very important thing for all of us that work with new mothers or pregnant women, is looking after yourself, is looking after the baby and looking after everything. So we also had for fathers Towards Parenthood. It's interesting because how do you bring men and engage men? First we had 2 books, and the men did not use the book. So we put it in one so they could use it together. And sometimes they do. So we use jokes, you know, your turn. And it was a workbook, so it's in a book, and we are hoping now to turn it into an e-program. And it has cartoons, exercises, and we tested it also with a weekly phone call, And not all women wanted the weekly phone call, but it seemed that some women liked doing the exercises and how did you go, how was it, once a week. We did a randomized trial. I won't take you through everything, but the results were good. We did find we were trying to prepare couples for the emotional journey to being a new mother. And we didn't specifically target depression and anxiety, but we actually, sorry. So we actually did find that 50% reduced in stress and anxiety, and particularly in terms of clinical depression. But it was more that the feedback we had, especially from focus groups, was that it had an effect on helping women move in thinking about, especially for first mothers, this is me and this is going to be me with my baby and my husband. So they told us very nice things, like every pregnant woman should read this book. That was very nice. What was very important too is we wanted them to think about, if I need help, how will I get help? So we tried to engage them with that as well. So part of our research has been to develop interventions. Another part of our research has been particularly to look at the effect on the baby, and so we are doing work on some very serious work on depression and child neurodevelopment. And we developed our program, Beating the Blues Before Birth, and we have trialled that program, not in monkeys yet, but in parents. And what we found in our preliminary pilot studies is that by treating depression in pregnancy, we were able to improve the child outcomes in the short term at 6 months. And we now have funding for a much larger study to try to replicate that study and to follow it to 2 years. In our pilot study, we also looked at some ongoing epigenetic changes and MRIs and so on. And it is really interesting that there is, quite a strong suggestion that we can make such a difference by treating promptly in pregnancy the depression and anxiety. We're also interested in parent-infant interactions, as you know. The time doesn't allow for me to really talk about these. I showed you that we have always been interested from the beginning on the effect of children. And we know, and this is what is, that short-term effects, and these are quite old studies because they were some of the most careful studies of depression on the child, is quite profound. But what really became even more disturbing is that there seems to be longer-term effects, not just for those women who have chronic depression, but specifically for those. But even if you've had a long period of depression, it appears that once the mother recovers from her depression, some relationship changes have become entrenched. And so we did a number of studies that showed that it was the mother-infant relationship that may be a mediating factor to some of the child outcomes later on, and that depression treatment is not enough, that treating depression is not enough. Even if you have CBT, it improves, but it doesn't improve necessarily to how you would like them to be compared to controls. So mother-infant difficulties endure after depression, and we were able to show that up to 42 months compared to control mothers who were not depressed. So you know the work of Lynn Murray and her group, who kept on following up these offsprings into adulthood, and has really made us realise that we must look at the mother-baby relationship, not just at the maternal symptoms of depression, because these impact on the child relationship. And of course, if you have a low mood and you are sad, how can you be joyful with your baby, look at your baby and you're, darling, it's very hard. You can hardly get out of bed. So we wanted to know, can we develop a very simple mother-infant interaction so once the woman has recovered from her depression, she can re-engage with her baby? And we developed baby hugs, and I'm not going to talk about it today, but I can answer some questions later. Very simple, 4 sessions. And we added it to, it's in the book, and we have continued to trial it. And it's quite a simple program, which now has been also developed into a community program, a longer program for nurses to run. But we have found that we can start to reverse that trajectory of ongoing mother-baby relationship difficulties. And if I can get this. So after we treat mothers for depression, we have mother-baby sessions. And in the first session, for example, we use play. Play and music is a wonderful medium for doing things. Later, we have the therapist here, and we have a mother and her baby. Later, now, I like using this because the therapist doesn't do exactly the right thing. So it's sometimes nice to see that even therapists can make mistakes, because the baby doesn't like this. Can you see? The baby's looking away. Now, what we're trying to teach mothers is to look at what the baby wants and only do it if they like it. But it's nice because it gives you the idea. He starts to get used to it, but he's not very comfortable. And that is something that we try to show. And the mother can see, she puts her hands out, and he goes back. But we use the play opportunity to help the mother understand the baby's cues, what the baby might need, to read the baby, and to make changes. And they're wonderful, really, groups. And so what we found, so they come in, and that's the parenting stress score. After the CBT program, it gets a little better. But just after 3 weeks, that's before the booster of this mother-baby play, it improves a lot. So now to introduce, which I won't talk about now because soon, I will stop a little soon because I know you're running late. I'll just show you about another 10 minutes. Okay. So I will talk about our e-programs later on because we'll talk about that after the break. So these are just pictures of our clinician decision support system for nurses. We're also doing work in the country to reach isolated women, and of our internet program. So you'll hear about that later. And you'll hear about how we're starting to develop programs for men. So this is now, for a while we didn't address pregnancy. Now we've known about all this. What about men? I'm just going to talk for a few minutes about some of the work we're doing, which isn't just for postnatal depression, but is to help parents who are having traumatic experiences after the birth of the baby. And of course, you know that when a baby is born premature, they have neurodevelopmental problems. So we know that babies who are born premature, early, have difficulties. But we also know that part of it is due to the disorganisation. The baby is born prematurely, the nervous system is not complete, there is other damage possibly. But the environment may be important too. And in fact, let me show you a few pictures. So this is what the baby at 26 weeks should be doing. If it's born early, this is how the baby is. So you can imagine how stressful that is for the baby. And yet we know that one of the things to help a baby develop is to contain anxiety and to sort of reduce stress. And so we developed an intervention for parents to come into the nursery and work with the baby to reduce the stress, to learn Premature babies don't do the same as babies who are born full term. They won't look you in the eye and so on. So you have to recognize more skin color changes, other changes. When is your baby telling you, do something, I need help, I need something else? Like a professional would be taught to understand it. And so they would be taught to do kangaroo care. They would be taught to touch their babies and try to reduce infant stress because it is so high. And it's increasing preterm birth, apparently. And the long-term effects are bad. But also the parents are having a pretty hard time. They may not have a full-blown depression, but they may be anxious. They may have some post-traumatic stress reactions. They may have some grief and loss and the couple relationships. So the parents need holding too. So we teach them how to relate to their babies. We teach them what to do, and this is just to show you what the brain of a baby at 40 weeks should look like. And so this is one baby's brain, not all babies' brain as dramatic as this, but the baby's brain is very different. But also, I went past this too fast. This is like, in a typical day, look how many things the poor baby has to endure to stay alive. It's important. They suction the nose, they unwrap him. And what we tried to do is develop how stressful. We asked the doctors and the nurses, how stressful is this for the baby? And so we also working with the nurses and the doctors to reduce how much they do at one point in time, not the heel prick and the nose suction and everything to allow the baby some space. So I'll just go to the end of our results. We did a randomized trial, and we were able to find that some early gains. Now, what's interesting is that nursery practices are improving, and so we're finding that we don't have so many later gains, but there were some early gains. And what's good is that around the world, now a lot of the premature nurseries are incorporating this, but the mothers and fathers then go home and don't exactly know what to do, so this training is still very relevant. So to build up to the break and to the needed coffee, what I will talk about is how we have translated some of our work, because all our research should be aimed at being out in the community, otherwise there's no point. And also, so what we've done is you will see some public health initiative I'll talk about. We also publish, so this is our screening book where we got world experts to talk about the challenges of screening. And so it was really a wonderful exercise where we got to know, it was really good because we thought we want to do a screening book. How will we find the experts and will they say yes? And we wrote to all the experts and they all said yes. So we made some very good friends, and I think it has some very nice information. So after the coffee break, I'm going to talk about our translational research, how we have taken and what we have done in the area of e-mental health in delivering over the internet our programs and other things like that. So Gina, do you want to tell people what happens now? Thank you.